Hi everyone, welcome to Learner's Way Access. Today I am going to talk about the abnormalities during the third stage of labor. Uh, Mainly, the main complication during third stage is PPH. There are some other complications also. We will discuss it. Actually, PPH is an emergency condition. It's an obstetric emergency. It needs prompt treatment as soon as possible to save the mother. So let us see what happens during PPH. Third stage abnormalities. The third stage is the most crucial one for the mother. Fatal complications may appear unexpectedly in an otherwise uneventful first or second stage. First and second stage uneventful रहा तो भी कोई complications कोई problem नहीं रहा तो भी third stage में problems हो सकता है. It's a crucial stage during the labor. The following are the important complications of third stage. They include postpartum hemorrhage, retention of placenta, shock, hemorrhagic or non-hemorrhagic shock, pulmonary embolism either by amniotic fluid or air embolism, uterine inversion. So these are the complications during third stage of labor. We'll see the first one, that is postpartum hemorrhage. Quantitative definition is arbitrary and is related to the amount of blood loss in excess of 500 ml following birth of the baby. This is according to WHO. That is, if there is more than 500 ml of blood loss after normal delivery, it is considered as a postpartum hemorrhage. PPH is considered as any of bleeding from or into the genital tract following birth of the baby up to the end of puerperium, which adversely affects the general condition of the patient, evidenced by a rise in pulse rate, falling blood pressure, is called postpartum hemorrhage. So, it is any bleeding during the puerperium period, starting from the third stage of labor up to the end of puerperium period, which causes various problems to the mother, the well-being of the mother. There will be significant tachycardia and low BP, which may lead to shock. The average blood loss following vaginal delivery, cesarean delivery, and cesarean hysterectomy is 500 ml, 1000 ml, and 1500 ml. Respectively. So after normal delivery, average blood loss is 500 ml. After cesarean section, it is nearly 1000 ml, and after cesarean hysterectomy, it is around 1500 ml respectively. Depending on the amount of blood loss, PPH can be minor, major, or severe. So कितने blood loss हुआ उसके हिसाब से PPH को minor, major और severe में divide किया हुआ है. Minor है तो less than 1 liter of blood is lost, major more than 1 liter of blood is lost, and severe cases more than 2 liters of blood is lost from the mother. Types of PPH, there are two types mainly, primary and secondary PPH. Primary hemorrhage occurs within 24 hours following the birth of the baby. In majority, hemorrhage occurs within 2 hours following delivery. These are of two types. So primary and secondary hemorrhage हो सकता है PPH में. प्राइमरी जो है विद इन 24 आवर्स 24 आवर्स के अंदर जो हेमरेज होता है उसको प्राइमरी हेमरेज कहते हैं. इसको दो में डिवाइड किया हुआ है, थर्ड स्टेज हेमरेज एंड टू पोस्टमार्टम हेमरेज. थर्ड स्टेज हेमरेज इज ड्यूरिंग थर्ड स्टेज बिफोर द एक्सपल्शन ऑफ द प्लासेंटा. प्लासेंटा एक्सपल्शन होने के पहले हेमरेज हो जाता है, इसको थर्ड स्टेज हेमरेज कहते हैं. और ट्रू पोस्टमार्टम हेमरेज इज ब्लीडिंग ओकर सब्सिक्वेंट टू द एक्सपल्शन ऑफ प्लासेंटा. प्लासेंटा एक्सपल्शन के बाद ब्लीडिंग continue रहता है, that is postpartum true postpartum hemorrhage. Secondary hemorrhage occurs beyond 24 hours and within puerperium is called delayed or late puerperal hemorrhage. So 24 hours के बाद भी hemorrhage continue रहता है. It is called secondary hemorrhage, or it starts after 24 hours, that also can be secondary hemorrhage. Causes, there are main four causes for postpartum hemorrhage. They are atonic. This is atonicity. There is no tone or the of the uterine musculature. Then that is there is no contraction. Then traumatic. Any injury to the genital tract is traumatic hemorrhage. Retained tissues, retained bits of placenta or blood clots uh, is called retained tissues causing uh, PPH. Then blood coagulopathies, that is coagulation disorders of the blood is called coagulopathy. We will see one by one. First, we will see the atonic uterus. It is the commonest cause. Nearly 80% of cases are due to atonic uterus. With the separation of the placenta, the uterine sinuses, which are torn, cannot be compressed effectively due to imperfect contraction and retraction of the uterine musculature, and bleeding continues. So, after the separation of the placenta, uterine sinuses, which are already torn, it is not compressed, it is not contracting and retracting properly. This causes the bleeding, continuous bleeding. Then the following are the conditions often interfere with the retraction of the uterus. They include grand multipara. In grand multipara, atonic uterus is very common. Over distance of the uterus, as in multiple pregnancy, hydramnios, big baby, etc. That is, if there is a big baby, diabetic mother, or multiple pregnancies, hydramnios, etc., can cause over distension of the uterus. Over distension की वजह से atonicity हो सकता है. Then malnutrition and anemia, that is the HB level less than 9 gram per dl dilution. So these people can have atonic uterus, antepartum hemorrhage. Both placenta previa and abruptio placenta can cause atonic uterus. Other causes include the causes of excessive long labor, more than 12 hours, poor retraction, infection, that is in case of like amnionitis, dehydration, etc. are important factors for tone of the uterus. Anesthesia, deep anesthesia, depth of anesthesia, and anesthetic agents may cause atonicity. Initiation or augmentation of delivery by oxytocin can be one cause. Mismanaged third stage of labor. Placenta morbid, morbid adly adherent placenta like placenta accreta, placenta percreta, etc. for precipitate labor, and that is the rapid delivery. All this can cause. Now the second cause is traumatic causes of PPH. Trauma to the genital tract usually occurs following operative delivery. Even after spontaneous delivery, blood loss from the episiotomy wound is often underestimated. After delivery, especially after this um, uh, instrumental operative delivery, there can be trauma to the genital tract. Usually the episiotomy wound also is bleeding, but it is not considered seriously. It is underestimated usually. Similarly, blood loss in cesarean section amounting to 800 to 1000 ml is most often ignored. Trauma involves usually the cervix, vagina, perineum, due to episiotomy wound, lacerations, etc., paraurethral region, and rarely rupture of the uterus occurs. This also causes bleeding. The bleeding is usually revealed but can rarely be concealed, like vulvovaginal and broad ligament hematoma are concealed bleeding. So all this can cause hemorrhage and PPH. Third cause is retained placenta. Bits of placenta and blood clots causes retained in the uterus can cause PPH due to imperfect uterine retraction. Then combination of atonic and traumatic causes can also be there. Then the fourth one is thrombin. Blood coagulation disorders, acquired or congenital, are less common causes of postpartum hemorrhage. The blood coagulopathy may be due to diminished procoagulants or increased fibrinolytic activity. The family retracted uterus can usually prevent bleeding. Example, abruptio placentae, jaundice in pregnancy, thrombocytopenic purpura, severe preeclampsia, HALP syndrome, etc. Prevention of PPH during antenatal period. Improvement of health status of the woman and to keep the hemoglobin levels normal, that is at least more than 10 gram per dilution. High risk patients who are likely to develop postpartum hemorrhage, like teen pregnancy, term news, grand multipara, APH history, or previous PPH, severe anemia. All these cases are high risk cases for PPH. They are to be screened and delivered in well equipped hospital. Blood grouping should be done for all women so that no time is wasted during emergency. Placental localization in previous cesarean delivery by ultrasonogram. Then all women with prior cesarean delivery must have their placental site determined by ultrasound or MRI. During intranatal period prevention, active management of third stage for all women in labor should be routine as it reduces PPH by 60%. So active management of labor करवाना चाहिए. Active management में जो है PPH 60% reduction in cases in active management. Then augmented labor by oxytocin, the infusion should be continued for at least 1 hour after the delivery. So oxytocin delivery देखो augmented जो labor है उसमें डिलीवरी के बाद भी 1 hour तक oxytocin infusion continue रखना चाहिए. Woman delivered by cesarean section, oxytocin 5 international unit. Slow IV is to be given to reduce the blood loss. So cesarean section delivery के बाद भी oxytocin 5 international unit slow IV continue रखना है. Carbetocin, this is a long acting oxytocin. 100 microgram is very useful to prevent PPH. Exploration of the uterovaginal canal for evidence of trauma following difficult labor and instrumental delivery is to be done. Observation for about 2 hours after delivery to make sure that the uterus is hard and well contracted. So postnatal period में 2 hours तक proper observation करना है मदर का यूट्रस वेल कॉन्ट्रैक्टेड है और हार्ड है और कोई ब्लीडिंग के चांसेस नहीं है ये कंफर्म करने हैं. Then during cesarean section, spontaneous separation and delivery placenta reduced blood loss. So cesarean section में अगर वेट करें placenta spontaneously separate होके आ जाए उससे 30% blood loss कम होने की chances है. Examination of placenta and membrane should be routine. Examination करके देखना है placenta को कोई lobes missing तो नहीं है, कोई gap तो नहीं है, कोई रिटेन प्लासेंटा होने की चांसेस तो नहीं है, मेम्ब्रेन्स इंटैक्ट है, ये सब चेक करना चाहिए आफ्टर प्लासेंटा डिलीवरी. Management of PPH. Steps of management includes placental site bleeding and traumatic bleeding. So placental site bleeding, how to manage it? To palpate the fundus and massage the uterus to make it hard. Uterus को सबसे पहले स्टेप है uterus को मसाज करना और फंडस एंड फंडल मसाज करना ताकि यूट्रस का कंट्रैक्शन को स्टिमुलेट करें और उसको हार्ड बना दें. Start crystalloid solution like normal saline or linear lactate solution with oxytocin 1 liter with 20 units. 1 liter solution में 20 units, that is 500 ml का bottle में 10 units डालना at and it should be given at a rate of 60 drops per minute and to arrange blood transfusion if necessary. So oxytocin drip देना साथ में blood transfusion के लिए blood arrange करनी है. Oxytocin 10 units IM or methalgin 0.2 mg is given intravenously. Oxytocin या methalgin. Then a patient को catheterize the patient, give antibiotics to prevent infection. We'll continue with the management. If features of placental separation are evident, expression of the placenta is to be done either by fundal pressure or control contraction method. Control contraction से placenta delivery कराना है. Then if the placenta is not separated, manual removal of placenta under general anesthesia is to be done. If the patient is in shock, she is resuscitated first before undertaking manual removal of placenta. If the patient is delivered under general anesthesia, quick manual removal of the placenta solves the problem. In cases where oxytocin 10 unit is given, IM with the delivery of the anterior shoulder, manual removal is done promptly when 2 attempts of control contraction fails. Creates the expression of the placenta is abandoned. Next is management of traumatic bleeding. The trauma to the perineum, vagina and the cervix is to be searched under good light by speculum examination. The uterovaginal canal is to be explored under general anesthesia after the placenta is expelled. Repair if there is tear of the tear or other injuries to the birth canal. Hemostatic sutures are placed on the offending sites. Hemostasis is achieved by appropriate catgut sutures. The repair is done under general anesthesia if necessary. Next, we will see the manual removal of placenta. The operation is done under general anesthesia. The patient is placed in a lithotomy position with all the aseptic measures. The bladder is catheterized. So, patient को general anesthesia देना है, patient को catheterize करना है with proper aseptic technique. Patient को lithotomy position में लेटाना है. One hand is introduced into the uterus after smearing with the antiseptic solution in cone-shaped manner following the cord. जो हाथ है उसको cone-shaped manner में पकड़ के जो कोड एम्बिलिकल कोड है उसको उसके लाइन से ऐसे डायरेक्शन लेके हाथ अंदर डालना है, यूट्रस के अंदर लेके जाना है. The fingers of the uterine hand should locate the margin of the placenta. जो हाथ अंदर यूट्रस के अंदर गया उसका फिंगर से प्लासेंटा का मार्जिन को लोकेट करना है. Counter pressure on the uterine fundus is applied by the other hand placed over the abdomen. दूसरा हाथ फंडस में लगा के उसको काउंटर प्रेशर देना है यूट्रस को. The abdominal hand should steady the fundus and guide the movements of the fingers inside the uterine cavity until the placenta is completely separated. So abdominal hand से फंडस को स्टडी करके पकड़ना है और जो हाथ अंदर है उसका फिंगर्स मूवमेंट को फिंगर मूवमेंट को गाइड करना है. So when the placenta is completely separated, it is extracted by traction of the cord by the other hand. So placenta एक बार separate हो गए तो उसको दूसरे हाथ से cord को traction देके धीरे-धीरे से बाहर निकालना है. Intravenous methargine 0.2 milligram is given and uterine hand is gradually removed while massaging the uterus by the external hand to make it hard. Inspect the cervicovaginal canal to exclude any injury. So intravenous methargine 0.2 milligram देना है पेशेंट को. यूट्राइन हैंड यूट्रस के अंदर जो हाथ उसको धीरे धीरे निकालना है बाहर से यूट्रस को मसाज करते हुए ताकि यूट्रस जो है कंट्रैक्शन में रहे, कंट्रैक्ट करते रहे. The placenta and membranes are inspected for completeness and be sure that the uterus remains hard and contracted. प्लासेंटा को प्लासेंटा एंड मेम्ब्रेन्स इंस्पेक्ट करना है, इंटैक्ट है कि नहीं देखना है और यूट्रस को मसाज करके उसको कॉन्ट्रैक्शन में ही रखना है. Complications of manual removal of placenta includes hemorrhage due to incomplete removal, shock, injury to the uterus, infections, invasion of uterus, subinvolution of uterus, thrombophlebitis, embolism. In such cases, placenta is removed in fragments using an own forceps or flushing a curette. Next, we will see the management of major PPH or the severe PPH. Management of major or severe PPH, immediate measures. Call for extra help, keep patient flat and warm. Send blood for full blood count, grouping and cross matching, diagnostic test, coagulation screening including fibrinogen, and ask for 2 units of blood. Infuse rapidly 2 liters of normal saline plasma substitutes like a hemocil to expand the vascular bed. Give oxygen by mask 10 to 15 liters per minute. Start 20 units of oxytocin in 1 liter of normal saline IV at the rate of 60 drops per minute. Transfuse blood as soon as possible. Management of the PPH. If the uterus is flabby, the bleeding is likely to be from atonic uterus. If the patient's uterus is firm and contracted, the bleeding is likely of traumatic origin. So, if the uterus is contracting and still bleeding, it is due to trauma. If the uterus is flabby and not contracting, that is an atonic uterus. The first step in common management of postpartum hemorrhage is the use of uterine stimulants, that is uterotonics, like oxytocin, ergot derivatives, prostaglandins, and misoprostol, and bimanual compression of the uterus. Recommend operative procedures for the management of postpartum hemorrhage include surgical repair or lower genital tract lacerations, uterine hypogastric artery ligation, and hysterectomy. First, the atonic uterus. How to manage atonic uterus? Massage the uterus to make it hard and express the blood clot. That is the first step. Methogen 0.2 mg is given. Injection oxytocin drip is started. Follis catheter is inserted and intake outputs are maintained. To examine the expel placenta and membrane. Second measure is explore the uterus under general anesthesia. Simultaneous inspection of the cervix, vagina, especially the parauteral area, and the refractory. In refractory cases, if refractory means if the bleeding is continuous after these measures, injection 15 methyl PGF2A 250 microgram IM. It is a potent uterine stimulant. Or misoprostol PG1 1000 microgram per is effective. When uterine atony is due to tocolytic drugs, calcium gluconate 1 gram IV slowly is given, should be given to neutralize the calcium blocking effect of these drugs. This is a picture of uterine massage. The fundus is massaged and squeezed out to express the blood from the uterus. Next is bimanual compression. The whole hand is introduced into the vagina in cone-shaped manner. The vaginal hand is clenched into a fist with the back of the hand directed posteriorly and the knuckles in the anterior fornix. So hand इंट्रोड्यूस कर देते हैं पहले वजाइना के अंदर, उसके बाद उसको क्लेंच करके फिस्ट बनाते हैं. उसका बैक ऑफ द हैंड जो है पोस्टीरियरली डायरेक्टेड होना चाहिए और नकल्स टू द एंटीरियर फोर्निक्स. द हैंड इज प्लेस्ड over the abdomen behind the uterus to make it antevated. So दूसरा हाथ जो है abdomen के ऊपर लगा के यूट्रस के पीछे से उसको पीछे की तरफ रखना है ताकि उसको antevated रखने के लिए. The uterus is firmly squeezed between the two hands. दोनों हाथ के बीच में यूट्रस को squeeze करके फ्लोट्स को बाहर निकालना है. Bimanual uterine massage का पिक्चर दिया हुआ यहाँ पे. One hand is inside the vagina and is clenched hand. Back of the hand is used here to compress the uterus from the vagina, and the other hand is placed on the abdomen just behind the uterus, and both the uterine fundus is in between both these hands, and it is compressed to express the clots and blood from the uterus. Uterine tamponade. Tight intrauterine packaging is done uniformly under general anesthesia. 5 meters of long strip of gauze, 8 centimeter wide, folded twice, is required. The gauze should be soaked in antiseptic cream before introduction. So a long gauze of 5 meters is folded and is double folded and taken to fill in the uterine cavity. It is already soaked in antiseptic cream and it is slowly uh, introduced into the uterine cavity, and it is filled uniformly inside the cavity so that it is tightly packed. Uterine cavity is tightly packed with gauze. Next is balloon tamponade. Tamponade using various types of hydrostatic balloon catheters, mostly replaced under packaging. Mechanism of action is similar to uterine pattern. So instead of gauze ribbons, here the balloons are used to inflate inside the uterine cavity so that it will press the arteries, bleeding arteries, and it will stop bleeding. Foley catheter, Beckery balloon, condom catheter or Seng's taken, Blakemore tube, etc. are inserted into the uterine cavity, and the balloon is inflated with the normal saline 200 to 500 ml. It is kept for 4 to 6 hours. That is a method of balloon tamponade. Other methods include non-pneumatic antishock garment may be used when the patient is being transferred to the referral center. Compression of the abdominal aorta may be temporary but effective measure. So in the first picture, you can see the gauze pieces packed into the uterine cavity. The second picture, it is a balloon, inflated balloon inside the uterine cavity. Both are having the same purpose of compressing the bleeding blood vessels. This picture shows pneumatic anti-shock garment. Then comes the surgical methods to control PPH. Surgical methods are the following: B-Lynch compression suture and multiple square sutures. Ligation of uterine arteries, ligation of the ovarian and uterine artery, anastomosis, ligation of another division of internal iliac artery, angiographic selective arterial embolization, and final measure is hysterectomy. So here you can see the B-Lynch uterine compression suture and ligation of the uterine arteries. Here you can see this is the suturing. This is sutured like this here. It is sutured and coming up to this. It is taken like this through the this cesarean opening, and it is again sutured from this side, and the string is coming from the other side like this, and both sides these are tied. So that is B-Lynch uterine compression, and here in this second picture you can see the ligation here. This one is ligation of the uterine artery. Uterine artery is ligated here so that the bleeding vessel is stopped. Next is uterine artery embolization. It has a high hemostatic capacity for PPH. Gelatin sponge particles are most commonly used primary embolic material for PPH embolization. Gelatin sponge particles are mixed with diluted contrast medium to produce a slurry, which is subsequently injected into the arteries under stasis or occlusion of blood flow is evident during angiography. So this procedure is done through an angiography, and the contrast medium is mixed with some gelatin sponge particles, and a slurry is made, and this slurry is introduced into the uterine arteries through the angiography. So that an occlusion of the blood flow is evident through the angiography. You can see the blood vessel is occluded, and so that the bleeding stops. That is uterine artery embolization. They enable temporary occlusion for 3 to 6 weeks and recanalization of the target arteries, which is advantageous for future fertility. So this occlusion is temporary, and it is done usually for 3 to 6 weeks, and it is recanalized for future fertility. Then disseminated intravascular coagulation has been reported as a risk factor associated with the failure of UAE, that is uterine artery embolization. So one complication associated with this uterine artery embolization is DIC. So in that case, N-butyl cyanoacrylate, that is NBCA, should be considered in patients with active bleeding and hemodynamically unstable conditions or failed embolization with gelatin sponge particles. Here you can see the uterine artery embolization. This is uterine artery. Here you can see this is uterine artery here, and this is the slurry which is introduced into the uterine artery, and the emboli you can see here. These are the emboli here, and it is blocking the bleeding vessel, that is uterine artery. Next is ligation of uterine, ovarian, and iliac arteries. You can see here the over the ligation done here. This is ligation. This is the ligation here. You can see this is the ligation of the ovarian artery so that the bleeding is stopped, and here is the ligation of the uterine artery here so that the bleeding stops. That is ligation of uterine and ovarian artery. And you can see the internal iliac artery. This is internal iliac artery here. This is the ligation done here. You can see this is the ligation done for the internal iliac artery. So these arteries are actually blocked so that the bleeding stops. The final measure is hysterectomy. Hysterectomy is surgical removal of the uterus. It may also involve removal of the cervix, ovaries, fallopian tubes, and other surrounding structures. Types of hysterectomy include radical hysterectomy, total hysterectomy, and subtotal or partial hysterectomy. Radical hysterectomy include the removal of uterus, cervix, upper vagina, and parametrium. It is indicated in cases of cancer. It is all the lymph nodes, ovaries, and fallopian tubes are also usually removed in this situation. Then total hysterectomy, complete removal of the uterus and cervix with or without oophorectomy. So total hysterectomy, the uterus, the body of uterus and cervix is removed, and in subtotal hysterectomy, that is partial hysterectomy, only the body of uterus is removed, leaving behind all other structures including the cervix. This is a picture showing the types of hysterectomy. You can see the radical hysterectomy, all the structures including the body of uterus. This is the body of uterus, then the cervix, the fallopian tube, and the ovary here. All these structures are removed. In partial hysterectomy, only the body of uterus is removed, and in total hysterectomy, the body of uterus, including the cervix, is removed. Next is the secondary postpartum hemorrhage. The causes of secondary PPH include retained bits of cotyledons or membranes. It is the most common cause. Second is infection and separation of slough over the deep cervicovaginal laceration. Then endometritis and some inversion of the placental site due to delayed healing process. Then secondary hemorrhage from the cesarean section wound usually occurs between 10 to 14 days due to separation of slough exposing the bleeding vessels or from granulation tissue. Withdrawal bleeding following estrogen therapy for suppression of lactation. Other rare causes are chorion epithelioma. Management. The principles of management include to assess the amount of blood loss and to replace it with blood transfusion, to find out the cause and take the appropriate measures to rectify it. Supportive therapy include blood transfusion if necessary, to administer methergine 0.2 mg IM, administer antibiotics to prevent infection. Conservative management if the bleeding is light and no apparent cause is detected. Careful watch for a period of 24 hours is or so is done in the hospital. That is the concept. Active treatment includes explore the uterus under general anesthesia urgently. Do not increase the amount of small amount of bleeding, as expected alarming hemorrhage may follow sooner or later. The products are removed by ovum forceps. General curettage is done by using flushing curette. Methadone 0.2 mg is given intramuscularly. The materials removed are to be sent for histological examination. Presence of bleeding from the sloughing wound of cervicovaginal canal should be controlled by hemostatic sutures. Secondary hemorrhage following cesarean section may at times require laparotomy. The bleeding from uterine wound can be controlled by hemostatic pressures. May rarely require ligation of the internal iliac artery or may end in hysterectomy. Now, the other complications of third stage of labor include retained placenta, placenta accreta, morbid, that is morbid adherent placenta, then the inversion of uterus. So these are the other major complications of third stage of labor. First we will see the retained placenta. The placenta is said to be retained when it is not expelled out even 30 minutes after the birth of the baby. After 15 minutes, if it is according to WHO, if it is the placenta is not expelled within 15 minutes, it is considered as a retained placenta. Causes of retained placenta include there are three phases involved in normal expulsion of placenta. The normal expulsion के three phases है वो है separation of the spongy layer of deciduous, then second one is descent into the lower segment and vagina, and third is expulsion to outside. So interference in any of these physiological processes result in retention. अगर placenta separate नहीं हुआ, separate होने के बाद वो जो है vagina में नहीं पहुंचा, लोअर सेगमेंट में नहीं पहुंचा, या फिर वो पहुंचने के बाद बाहर निकला नहीं, ये कोई भी रीजन हो सकता है रिटेन प्लासेंटा होने के लिए. प्लासेंटा completely separated but retained is due to poor voluntary expulsive effort. प्लासेंटा सेपरेट होने के बाद अगर नहीं निकल रहा है तो उसका मतलब है voluntary expulsive effort of the uterus is not there. That is why. Simple adherent placenta is due to uterine atonicity in case of grand multipara or distension of uterus, prolonged labor, and uterine malformation due to bigger placental surface area. So the commonest causes are atonic uterus, morbid adherent placenta, that is partial or rarely complete morbid adherent placenta, then placenta incarcerated following partial or complete separation due to constriction ring. Constriction ring or hourglass contraction. The placenta, either unseparated or separated partially or completely, may be trapped by localized contraction of circular muscles of the uterus. So in constriction ring, the separated or unseparated placenta is being trapped inside the uterus because of the ring formed. So the causes of constriction ring include administration of any oxytocin, especially ergometry in active management of third stage, or undue irritability of the uterus by premature attempts to express the placenta. Here you can see the picture of hourglass contraction or the constriction ring. Here there is a ring formed at the junction of the upper uterine segment and the lower uterine segment. This is upper uterine segment. You can see this is upper uterine segment and this is lower uterine segment. In between there is a constriction formed here. On both sides there is a constriction. So here you can see this is constricted and it is preventing the uterus, the baby or the placenta, whatever is inside the uterus, it will prevent this due to this constriction at the junction of the lower and upper uterine segment, and it will not come down. That is constriction ring. Management is the uterus is made to relax by deepening the plane of anesthesia, that is halotene. Then the cone-shaped hand is introduced and the separation of the placenta is preferably done from above downward to minimize the bleeding. So patient is given anesthesia and the manual removal is done in case of constriction ring. Retained placenta, कई तरह का retained placenta हो सकता है. First case is रिटेन प्लासेंटा विद शोक बट नो हेमरेज। रिटेन प्लासेंटा है पेशेंट शोक में लेकिन हेमरेज नहीं, उसको क्या करना है? सबसे पहले शोक का ट्रीटमेंट देना है और जब जैसे पेशेंट का कंडीशन इंप्रूव होगा मैनुअल रिमूवल प्लासेंटा कर देता है। देन सेकंड केसेस रिटेन प्लासेंटा विद हेमरेज। रिटेन प्लासेंटा के साथ हेमरेज भी है, उसको क्या करना है? मैनेजमेंट प्रोटोकॉल इज सिमिलर टू दैट ऑफ थर्ड स्टेज हेमरेज। इसको मैनेज करना है जैसे थर्ड स्टेज हेमरेज में मैनेजमेंट किया उसी सेम वे में मैनेज करनी है यहाँ पे। देन रिटेन प्लासेंटा विद एपिसोटोमी वुंड। रिटेन प्लासेंटा एपिसोटोमी वुंड के साथ है तो ब्लीडिंग पॉइंट्स को पहले सिक्योर करना है एक आर्टरी फोर्सेप्स यूज करके, उसके बाद मैनुअल रिमूवल प्लासेंटा करके उसके बाद एपिसोटोमी वुंड को जो है क्लोज करनी है, दैट इज अ मैनेजमेंट। Then fourth case is retained placenta with sepsis. The patient is usually delivered outside and is admitted in referral hospital after few hours or even days after confinement. So patient ये जो sepsis के साथ अगर patient आ रहा है retained placenta के साथ, ये usually बाहर डिलीवरी करके पेशेंट को जैसे प्रॉब्लम्स हो गया उसके बाद इधर बड़े हॉस्पिटल में या मेडिकल कॉलेज वगैरह में लेके आ जाते हैं, उसको कैसे मैनेज करना है? इंट्रायूटेराइन स्वाब्स आर टेकन फॉर कल्चरल सेंसिटिविटी टेस्ट एंड ब्रॉड स्पेक्ट्रम एंटीबायोटिक इज स्टार्टेड। सो पेशेंट को इंट्रायूटेराइन स्वाब्स लेके सीएनएस कल्चरल सेंसिटिविटी के लिए भेज देते हैं, उसके बाद उसको ब्रॉड स्पेक्ट्रम एंटीबायोटिक स्टार्ट करना है इन्फेक्शन को हील करने के लिए, क्योर करने के लिए। ब्लड ट्रांसफ्यूजन is given then as soon as the general condition permits arrangement is made for manual removal। पेशेंट का कंडीशन थोड़ा बेटर होने के बाद manual removal of placenta करना है। नेक्स्ट कंडीशन इज प्लासेंटा accreta, morbid adherent placenta। सो द यहाँ पे प्लासेंटा काफी बुरी तरह से अटैच हो रखी है, अडहेर हो रखी है या चिपकी हुई है उसका यूट्रस के साथ, उसको निकालना मुश्किल हो जाती है, दैट इज प्लासेंटा accreta। प्लासेंटा accreta from form in which the placenta is directly anchored to the myometrium partially or completely without any intervening residue। सो यहाँ पे क्या होता है प्लासेंटा accreta में, ये जो प्लासेंटा जो है डायरेक्टली मसल में जाके एंकर हो रखी है, इसको इसलिए इतना उसको डीपली एंकर्ड है, इसलिए इसको रिमूव करना मुश्किल हो जाती है। इन प्लासेंटा इन पार्शियल प्लासेंटा accreta remove the placental tissue such as much as possible, effective oxytocic and intrauterine plugging is done। पेशेंट को जो जितने पॉसिबल है उतने प्लासेंटल टिश्यू रिमूव करना है, उसके बाद ऑक्सीटोसिक्स देना है पेशेंट को, इंट्रायूट्राइन प्लगिंग करना है। इफ द यूट्रस फेल्स टू कॉन्ट्रैक्ट हिस्टेरेक्टोमी शुड बी डन। अगर कॉन्ट्रैक्शन इसमें स्टार्ट नहीं हो रहा है यूट्रस का सो हिस्टेरेक्टोमी कर देते पेशेंट का। देन इन टोटल प्लासेंटा accreta, टोटल प्लासेंटा कम्प्लीटली मसल में अटैच हो रही है, प्लासेंटा उसको निकालना बिल्कुल मुश्किल है, पॉसिबल नहीं है, उसको हिस्टेरेक्टोमी करना पड़ेगा। देन इफ प्लासेंटा accreta इन्वेड द ब्लैडर, प्लासेंटा accreta अगर ब्लैडर में भी इन्वेड हो गया, ब्लैडर में भी अटैच हो रही है, तो उसको रिमूवल नहीं करते इसका क्योंकि ब्लैडर डैमेज हो जाएगा। सो इट में नीड हिस्टेरेक्टोमी एंड पार्शियल सिस्टेक्टोमी। सो यहाँ हिस्टेरेक्टोमी भी करते हैं, उसके साथ पार्शियल सिस्टेक्टोमी जहाँ पे अफेक्टेड है वो एरिया ब्लड का वो भी निकाल देते हैं, that is being done in this case। Next condition is inversion of uterus। Here you can see this fundus, this is fundus of uterus, वो थोड़ा सा अंदर की तरफ आया हुआ है, ये देखो there is a dimpling of the uterus into the uterine cavity, इसको कहते हैं inversion of uterus। यहाँ पे थोड़ा सा अंदर आया हुआ है इसलिए इसको फर्स्ट डिग्री इन्वर्शन कहते हैं, दिस इज फर्स्ट डिग्री। देन यहाँ जो है दिस इज सेकंड डिग्री इन्वर्शन, ये काफी अंदर आ चुका है, ये सर्विक्स तक आ गए, ये इसको कहते हैं सेकंड डिग्री इन्वर्शन। एंड दिस इज थर्ड डिग्री इन्वर्शन, यहाँ पे ये जो है सर्विक्स से ही बाहर आके वजाइना से भी बाहर आके बाहर से दिख रहा है, ये यूट्रस पूरा बाहर आ चुका है, इसको कहते हैं थर्ड डिग्री inversion of uterus। So inversion of uterus, it is an extremely rare but life-threatening complication in third stage in which the uterus is turned inside out partially or completely। So uterus जो है inside out हो जाती है, अंदर की तरफ आ जाती है और बाहर आ जाती है, वो इसको ये एक लाइफ थ्रेटनिंग कंडीशन है, ये थर्ड स्टेज में हो सकता है। पार्शियली या कम्प्लीटली ये बाहर आ जाती है. इंसिडेंस है 1 in 20,000 डिलीवरीज. इसका varieties include first degree, second degree and third degree. First degree, there is a dibbling of fundus which will remain above the level of internal lobe. Second degree, the fundus passes through the cervix but lies inside the vagina. Then third degree, the endometrium with or without the attached placenta is visible outside the vulva. The cervix part of the vagina may also involved in the process. Management of inverted uterus. To place the part, to replace that part first which is inverted last with the placenta attached to the uterus by steady firm pressure exerted by the fingers. So जो last part जो invert हुआ उसको पहले replace करते हैं placenta के साथ firm fingers pressure के साथ pressure से. To apply counter support by the other hand on the abdomen. Abdomen में दूसरे हाथ से counter pressure देते हैं. After replacement, the hand should remain inside the uterus until the uterus becomes contracted by parental oxytocin or PGF2A. So जो यूट्रस को रिप्लेस करने के बाद हाथ अंदर ही रखना है जब तक उसका कॉन्ट्रैक्शन शुरू नहीं होता है. कॉन्ट्रैक्शन शुरू होने के लिए ऑक्सीटोसिन दे सकते हैं या फिर PGF2A दे सकते हैं. The placenta is to be removed manually only after the uterus becomes contracted. Placenta यूट्रस कॉन्ट्रैक्ट होना शुरू करने के बाद प्लासेंटा निकाल देते हैं. The placenta may however be removed prior to replacement or to reduce the bulk which facilitates replacement, or if partially separated to minimize the blood loss. So placenta either placenta जो contraction शुरू होने के बाद replacement के बाद निकाल देते हैं या फिर placenta replace करने के पहले भी निकाल सकते हैं ताकि जो placenta निकालने से वो जिसको bulk है वो थोड़ा कम हो जाता है तो replace करना आसान हो जाता है. या फिर partially separated placenta है तो पूरा separate करके उसको निकाल देते उसके बाद placenta replacement कर सकते हैं. दोनों तरीके से कर सकते हैं. Usually treatment of shock including blood transfusion should be arranged. पेशेंट को शॉक हो सकता है तो शॉक ट्रीटमेंट के लिए पूरा अरेंजमेंट करना चाहिए. ब्लड ट्रांसफ्यूजन के लिए भी अरेंजमेंट करके रखना. So that's all about the third stage complications of labor. I hope all of you understood. If you have any doubts, you can clarify it with me. Thank you so much for watching.